Okay.
And here, started the timer, and here is your question.
Okay. So I will start.
You read the question 1 minute.
Okay. Consider
After
the
1
method.
minute, bell will go, and then I'll tell you to begin the examination station. Right. So if you have read and understood, considering it clinical examination station, kindly begin your station now.
Yeah. Hello, I'm Dr. Daffer, one of the surgical doctor looking after you today. Could you confirm your name and date of birth, please?
I'm Smith, 57 years old.
Nice to meet you. Our today, we need to examine your chest, and this part we need to expose your chest from the waist, and also we need to looking, feeling, percuss, and auscultate your chest. Is that okay?
Yes.
So we starting in generally by looking for the patient and around the patient. If there is cyanosis, dyspneic, tachypneic, cyanosis, or cachaxic, I starting with the knees. Could you put your hand in front of me, please? I'm looking for the back. If there is cyanosis, any scar, searching for clumping, hand test for clumping. And could you please turn your hand and facing up? Okay, that's good. No cyanosis. I start to check refilling, pulse, and blood pressure. I go to the chest, to the head, looking for the eye. If there is cyanosis, if there is anemia, looking at the mouth, if the angular stomatitis, if there is cyanosis, anemia. I'm looking for the neck, if there is any jugular vein, for examine for jugular vein, if there is elevated, and goes to the chest. After expose the chest, I'm generally looking for the chest exam. If there is any scar, looking for the site for chest tube, thoracotomy, sternotomy, pacemaker. I check that, and also I check respiratory rate. Then I go to feel, looking for the respiratory rate, and if they use accessory muscles. I'm starting with the feeling. I warm my hand. I think it's hot now, so I starting to localize the trachea central. I measure the cricosternal measurement and palpate the chest, epic speed, expansion of the chest, and then we'll go to examine the lymph node also, and focal fremitus, then percussion above the clavicle, on the clavicle, and the anterior chest wall, lateral chest wall, and all that. And then we'll do focal resonance and auscultate the chest anteriorly. After that, I will need to turn the patient to examine from the posterior side, also inspection, palpation, percussion, and auscultate. And also looking for the presacral edema and also for the leg edema.
Good.
So after that, I finish all my exam. I need to, as I was said, we need to expose the back from the back side, from the backward examination of the back, sorry, and we will do some investigation. Is that okay? Okay, I'm finished.
Just okay, all right. Can you present your? You still had 2 minutes, but can you present your case now?
So, I examined 75 years old male. He's presented with the cough, and low-grade fever. Here, by inspection, I'm looking for the tar skin, the clumping, if there is any cyanosis, dyspnea, the kidney, there is no, according to the case, unfortunately, according to the case. I also examine the jugular vein, GVP, trachea central, cricosternal 3 cm or 4 cm, according to the case. And by the inspection, the chest move, respiratory rate, blood pressure, I will say the respiratory rate, blood pressure, pulse rate. And also, by the inspection, I looking, there is no scar, no use of accessory muscles. Okay.
Okay, so what are your differential diagnoses?
For this case with the smoking, I think it's about it is cardio COPD.
Okay.
Yeah, but I need to exclude other cause,
Like?
such as pneumonia.
Okay, and you have to tell me 3 more. Yes.
Yeah.
Okay, so how would you confirm your diagnosis? What investigations would you ask
I will
for?
send him for simply a chest X-ray, erect position, and also send him for the blood test.
Okay, anything else?
And the respiratory and pulmonary function test.
Okay, spirometry and respiratory function
Yeah.
test. Okay, what management can you offer to this patient, considering patient is smoker and hypertensive as well?
So for this case, he's arranged for operation. So I need to contact the GP to optimize the general condition for this case.
Good.
Firstly, and also treated the infection, control hypertensive because he's on fever.
Yes.
So,
Yes.
and also started smoking 6 weeks before the operation.
Yes.
And I will send him for physiotherapy before and after, and I will optimize the condition. And if the surgery there's many surgical options. So open surgery, it is better than laparoscopic surgery, and regional anesthesia, it is better than general anesthesia.
Okay.
Okay.
And if patient needs laparoscope, if patient needs operation, so you'll prefer laparoscopic or
no, open
Okay.
open surgery, because the keyhole or laparoscopic surgery
Okay.
is called
Who would you
oxygen.
involve in the management of this patient?
I will involve my supervisor, consultant surgeon, and
Yes.
also anesthetic consultant.
All right, good. Okay, you still have time. All right. If time would have allowed you, how would you have completed your examination?
So, sorry?
How would you have completed your examination? What else would you have done? What else would you have examined?
For this case, I will examine the leg edema. And
You mentioned leg edema, cardiovascular examination of this patient.
Yeah.
Yes, because patient is smoker and hypertensive. So you have to, if time would have allowed, you would have done cardiovascular examination. Good. You still have 15 seconds. So that's why I'm asking. All right, good, very good. This was your first time with us.
I appreciate your help.
You covered everything. I'm waiting for the bell. Right. Okay. Now you covered everything, and considering it that you are doing it for the first time with us, when you were examining, you did say you'll examine the hand. So one thing that you'll examine, because patient is a smoker, so you'll examine for the tar staining on the fingers.
Yeah.
Yeah. And you forgot to mention that. And then you did mention everything. It's just the small things that you forgot. I'm just reminding, otherwise like it's a pass from my side. Right. Then when you were examining, when you were examining or when you were palpating the chest, you had to mention about the chest expansion. How would you measure the chest expansion?
I say that there is two rules for measurement chest expansion. I by the tape measure,
Yes.
or by the put hand around the chest and
Yes.
thumb in front is the sternum, and told the patient to take deep breath
Yes.
and looking if there is symmetry or asymmetry.
Very good. Very good.
Yeah.
Just that. And then percussion. Once you're
Yeah.
doing percussion, you
Yeah.
have to ask the patient to say something. This you have forgotten, percussion.
Yeah.
And then when you were looking at, okay, the inspection of the chest, you had to look at the shape of the chest. You mentioned the scar, but the shape, because
Yeah.
if you think patient is COPD, then
Yes.
barrel-shaped chest or pigeon-shaped chest or whatever is abnormal, like
Yeah.
some people with the Marfan syndrome have.
Yes, it's maybe barrel chest and
Yes.
AP diameter is more
So,
than
yes.
the lateral diameter.
So
Yes, that's
Chest
fine. I was.
shape is very important. You have to
Yeah.
look at. And then you said auscultation. So because you still had time, you could have taken it easy and you could have mentioned more. When you auscultated, okay, you auscultated for the quality, for the volume, and if there
Yeah.
were any added sounds that you heard.
Yeah.
Since patient is smoker, so it's possible that you can hear some
Wheezing or
resonance or wheezing or anything, some extra sound. So that, right. And
yeah.
you did mention about repeating everything on the back, so it was very
Yeah.
good. You did mention about examination of the lymph nodes, so it's excellent. Vocal resonance, you also added. So these are just the small things that in real life, when because now examinations are taking place with the patients. So
Yeah.
once you are doing it with the patient and examiner is sitting there and watching you doing it, so take your full 6-minute time and do everything repeatedly. So I request everyone to perform each for the sake of practice 30 times, 30. So if you'll do this after listening to this examination 30 times, normal respiratory system examination, there's no way that you'll forget anything in the exam. So good, thank you. Okay, started your timer and here is your question, please. Right, so if you have read and understood, considering a clinical examination station, kindly begin
Yes.
your station.
Yes, I will start by wash my hands.
Yes,
Good morning. I am Mr. Al-Ghaziri, one of surgical doctors here. Can I confirm your name and age, please, sir?
I'm Tom, 55 years old.
Nice to meet you, Tom. Today I'm going to examine your chest. Let me include look, listen, and tap and feel your chest. Do you agree with this?
Yes,
Do you have any pain at the moment?
yes, little.
Yes. Are you in need for painkiller or analgesia now?
No, that's okay.
So as regard the patient is appearing in critical care, so I couldn't examine in formal chest examination. I will manage according to CRISP protocol in form A, B, C, D, E. I will start the patient is talking, so the patient has patent in way, but I
Very
just
good.
need to consider to put oxygen mask on 2 liter for the
Yes.
patient and put pulse oximeter to detect the oxygen saturation. So now I will go for breathing. I will ask the patient to lay down on the couch, please, sir. Then expose your gown from waist up and exposing also your lower legs, your legs. Now I will detect the respiratory rate and ask the patient, open your mouth, please, and stick your tongue up to detect central cyanosis. Also, now I will feel your windpipe may be a little bit uncomfortable to detect any deviation of the trachea.
Good.
Then after that, can you please, do you have any shoulder pain? If you don't have, please lift your arms up to detect any chest scars or so on. Now I feel your chest, please. I will take your chest or wrap your chest between my hands and put the thumb towards the sternum according to 3 zones, sopra and infra and the mammary zone. Then I will ask the patient that now I will listen to, I will tap on your chest, maybe a little bit uncomfortable. I will start by supraclavicular and then 3 zones according to mid-clavicular line and also anterior axillary line lateral to detect any hyperresonance to exclude pneumothorax. And then now I will listen through your chest. I will through 3 zones, sopra and infra, and according to mammary to detect the added sound or wheeze or decrease air entry. Now, please, can you with crossed your hand, please? Can you lean forward? Now I will examine you from your back. Then I will tap and I will do chest movement evaluation by putting my hands and 2 thumbs toward the midline and ask the patient to take breath in and out to detect any limitation of movement. Also, now I will tap through your chest at the back to detect any hyperresonance. Also listening, and it's the same. I will ask the patient to say 99 either in the anterior and the posterior examination.
Good.
According to the breathings, now I will go through circulation. I will search for any sunken eye by general look to detect any dehydration. I ask the patient to open your mouth, stick your tongue out also to detect any dehydration side dry tongue. I will ask the patient, please, can you look to the other side to detect any congested neck vein? And also I will look for I will feel your hands, please, to detect any peripheral hypothermia. And I feel pulse in your hands. And I will also squeeze your fingers to detect any delayed capillary fill. Now I will feel your heart and will detect the apex. Where is it? By counting from the sternal angle. Left fifth clavicular line. Then I will listen through your heart to detect the S1, S2 heart sound and any audible murmurs. Through 4 area, left mid clavicular line, mitral area and sternal area, fourth sternal border and pulmonary aortic area. Second, left sternal border and aortic area to the right and aortic area to right sternal border, right intercostal space. This according to the circulation. Now I will go through disability. The patient is conscious and alert, but I will also detect the pulse oximeter, the pulse. Also now through the exposure, I will go for to detect any tenderness of the lower of the calf muscle. Please, sir, I will squeeze your muscle of your legs, maybe a little bit uncomfortable to detect any tenderness. And also we search for preventive measures for DVT in form of thromboembolic deterrent stocking. And I will also measure the temperature for the patient. And for the hip surgery, I will ask the patient to, I will expose the surgical wound or the incision to detect any complication of the surgery. Now I will ask for the chart review for the patient and the drug review to detect any deterioration in vital signs in relation to now, and also search for any missed dose for subcutaneous heparin. Now I will thank the patient and say you can rest now. I will pass my notes to my consultant.
Good.
So
can you present your case now? Yes.
Yes. So as regards this patient, I examined Sir Thomas, 55-year-old, who presented day 8 post hip replacement, right hip replacement, who is presented with acute pleuritic pain, shortness of breath. On examination, there is tachypnea and but equal air entry and the equal chest movement and the normal resonance, that making pneumonia and pneumothorax less likely. And according to the I examined him according to ABCDE protocol. Circulation, no delayed capillary fill, but there is a tachycardia, no congested neck vein, no central cyanosis, and no lower limb edema. The patient is conscious and alert with patent airway. But I examined the chart review and drug review, and he missed 2 doses of subcutaneous heparin. So my top differential diagnosis is pulmonary embolism, and less likely pneumonia and pneumothorax, but myocardial infarction due to the age of the patient is less likely, but is considerable. So I will wait for troponin and the ECG. So according to this, I will manage the patient according to, as I mentioned, ABCD protocol.
Yes.
But I will order some investigation. The most important one, assuming normal renal function, is CT pulmonary angiography, but also chest X-ray, duplex in the lower limb for veins, ABG, D-dimer, ABG, and ECG also.
Yes. What would you look for in the ECG?
ECG. So as regarded the right axis deviation, there is a deep S in lead 1, pathological Q lead 3, and T inversion lead 3, and for pericardial axis from V1 to V4.
Okay, considering a pulmonary, yes, please. Considering a pulmonary embolism, how do you plan to manage this patient?
Yes, according to the patient is hemodynamically stable or not stable. If the patient is not stable, I will crash code blue for thrombolysis or embolectomy. If the patient is hemodynamically stable, I will give the patient subcutaneous heparin, 70 units per kg, adjusted by 15 later on, till BTT is 50 to 60. Second, then after that, I will put the patient on warfarin, including the medical team responsible for the management.
Very good. So just suppose you were scrubbed and you get to hear this news about the patient to a nurse. What would you do immediately?
Crash code blue.
Very good. Very good. Okay. Is there anything else you'll do to complete your examination? If time would have allowed you?
Anything for what?
Anything else to complete your examination?
Yes, a complete cardiovascular examination.
Yes, good. Yes, good. So I think you covered everything. Anyone else want to give feedback? We have Dr. Hamdi back. Can you give feedback, Dr. Mohammed? I think you covered everything.
No, he covered everything.
He covered everything. I myself was talking, Dr. Dafar. Would you want to give feedback? Has he missed anything?
For me, just a minute. I'm looking for. Okay. For me, yes, I can add something. He's brilliant, but he's know everything about the case. So if the examiner he's thinking he's prepare this case in such way, he's sometimes and accept that and one of his words he said, sir, just say in the for surgeon in the UK and also for soldier. This is one by inspection and ABC. You should focus more in history taking about the pain for this case, and cover all things about pain history, and then go to examination, not more detail, just A, B, C, D, E. You give more detail. This is very good, but there's no time for you, because sometimes I did this station. I did this station in my last exam, so I know everything about this case.
Yes.
So
right.
So we don't need to go more detail.
Yeah.
And not all detail the same every exam, because in this exam they didn't show X-ray, ECG or X-ray They didn't give you oxygen saturation. They didn't give.
In real exam, they will give you. I didn't give you.
Yeah, I did this station. They didn't give me that.
Okay. Can
They
I
didn't
ask
give.
you where you appeared? In which center?
Oh, excuse me. I did exam in the London.
Okay, UK.
So
Right.
they didn't say me all these questions. The question it is a little bit differ.
Okay,
But
what did they ask you?
So they asked me about differential diagnosis.
Yes.
About the chart. The chart we should be looking at the chart, and the chart it's normal, completely normal. So they didn't give me the oxygen saturation in this situation, and they didn't ask me about X-ray or ECG.
Okay. So that means
sometimes a little bit it's differ. We should know the structure, how to go the structure and answer the question.
Yes. Yes, but one thing I wanted to add, Dr. Mohammed, since it's a post-op patient, so more, and it was hip replacement, so patient would have had a band, but that was already good that, okay, patient was speaking already and patient was alert. So when you asked and introduced yourself and took the consent and confirmed the identity by speaking to the patient, you did mention as well that patient is alert and talking. So that was kind of covered, but just suppose in examination, patient is actor, and then patient is lying down and not talking or responding to you. But then how would you confirm patient's identity? By looking at the band on the hand. Patient's ID will be given on the hand, in the band around the hand.
Bracelet, maybe medical bracelet in the hand.
Yeah. Because patient may not speak, may not talk, but will look drowsy. Patient will have oxygen mask on it. So you will confirm if oxygen mask is there, how much oxygen is being given. And like Dr. Dafa said, patient chart that they give you in examination, they appear normal because before the patient had chest pain, it's sudden chest pain. They took the vitals and everything and they appear to be normal, right? So this is another factor or another thing that convinces you that since it's sudden and before this chest pain, everything was normal. That's why I suspect, like he said, Dr. Muhammad said, like pulmonary embolism or MI. But then he had to wait for them and for the ECG. And he did say that he'll ask for the ECG, he's awaiting. And I asked him, what would you look for in the ECG? And he told.
And
what else was your question, Dr. Dafa?
And on examination, when I said posteriorly, he said, in this situation, he's on severe pain, dyspneic, tachypneic.
Yes, you will not turn around the patient. Yes.
Yeah.
Yes.
The question is.
Yes, it's emergency situation, so you won't be turning it around. Okay, good. Anything else we should?
As regard, ma'am, please just note one note.
Yes,
as regard the leaning forward for posterior examination, this case has two scenarios. The first one, if the patient underwent abdominal surgery and he is coming for leak, and after that the patient developed chest pain. This is the patient has peritonitis. At this, I can't go for posterior back examination for the chest.
In pulmonary embolism, you will examine the chest
from
the back.
Yes, back.
Will.
Yes. This as regards the first point. The second one, as regard, I will take the history of the pain, and no chance to take a history during the examination.
In examination station, you should not.
Yes, and you just allow to do examination without talking with the examiner or patient. Just you can notify the patient that I will do that, and just let me know if you catch or have any pain.
Yeah.
But as regard the detailed history of the chest pain, it will not be eligible for this case. And as regard the chart or drug chart or patient chart, may be normal and may be abnormal, as
Yes.
pulmonary embolism occurred, as you mentioned, that a normal patient with sudden onset of pleuritic chest pain. It's
Yes.
just top differential diagnosis, but not final diagnosis.
No.
The goal of or the aim for this scenario is how to approach CRISP patient or
Yes.
advanced life support patient through
Yes.
ABCDE approach about
Yes.
evaluation in
Yes.
hurry and about management in investigation and how to hurry in management if you stuck in job, as you mentioned, in if you are scrub or
Yes.
if you are one of the medical team. This is my point of view, and
Okay.
I have covered this scenario.
Yes. Yes.
I appreciate that. I will send for you the scheme mark for this case. The first one, wash your hand, introduce yourself and rule. Second one, take a focus history of chest pain, including side character associated symptoms. To know there is severe pain, you cannot judge and you cannot proceed in the normal process. I will send this in the group.
Okay.
The scheme mark.
Good. Thank you. But one thing, in examination, you should not take the history. You should not waste your time. But like if you ask for the consent, if patient is having pain and patient refuses to follow your instruction or cannot follow your exam, or you are, when you're examining, you're eliciting pain to the patient, you should not continue with the examination. And you should say that examination causes pain to the patient, I will not be able to continue forward. Or if patient refuses, the moment you put your hand on the patient and patient screams, you'll fail. You are not supposed to give pain to the patient. The moment you do, examiner will fail you. So yes, you have to be polite, you have to be gentle, and you should ask if you are having any pain before examining. And like you said that your hands are warm before you'll touch. So okay, you'll warm your hands and then you'll say okay. Or if your hands are cold, you'll rub against each other and then you can say okay, my hands are cold, they may cause you discomfort. So started the timer and here is the question. Right, if you have read and understood, considering it's surgical and not station, please tell me how shoulder joint is formed. Can you identify
shoulder
the
joint?
bones? Yes, please.
Yes, shoulder joint is formed by the articulation between three bones,
Yes.
The scapula, the humerus, and the clavicle.
Yes.
And the mark A is the scapula seen from posterior, and mark B is scapula seen from anterior.
Okay, good. Can you tell me what 11 is?
11 is the subscapularis fossa.
Okay, what muscle is attached here?
Subscapularis muscle.
Okay, can you please tell me how rotator cuff is formed?
The rotator cuff is formed by 4 muscles. First one is the supraspinatus. The next is infraspinatus, teres minor, and the last is subscapularis.
Okay, good. Can you tell me their nerve supply as well? Which nerve supplies the muscles of the rotator cuff?
The suprascapular nerve supplies two muscles, supraspinatus and the infra by the axillary nerve, and the subscapularis is supplied.
Okay, good. Can you tell me what is 2?
Two is the acromion.
Okay, and 5?
5 is the body of the scapula.
15?
15 is the supraspinous fossa.
Supraspinous fossa, yes, good. Okay, can you tell me there are 2 triangles around here, around the shoulder joint. Can you tell me what are those? Or the boundaries of the, yes.
The boundaries of
Quadrangular.
2 triangles are,
Yes.
There's a quadrangular space and
Yes.
2 triangles formed by the teres major and teres minor muscle, and the trapeze, the long head of triceps, and the humeral proximal humerus bone. And the boundaries of the quadrangular space are the teres minor superiorly,
Yes.
teres major inferiorly,
Yes.
and laterally the surgical neck of the humerus, and medially the long head of the triceps.
What are the contents of quadrangular space? What
The
passes
contents
through it?
are the axillary nerve and the circumflex humeral vessels.
Vessels. Okay, good.
Posterior circumflex.
What lies in the groove of bicipital groove? Or what are the contents of contents of the bicipital groove? Tendon of the biceps or long head of the biceps in the groove. Okay. Can you please tell me what are the movements which are present or which are allowed by the shoulder joint?
The movements in the shoulder joint are flexion, extension, adduction, abduction, then internal rotation, external rotation.
Okay. Can you please tell me which muscle is responsible for the abduction of the shoulder joint?
The initiation of abduction is by supraspinatus muscle,
Yes.
and further abduction from 15 degrees to 90 degrees is by deltoid muscle, and
Yes.
further abduction is with the help of serratus, trapezius and serratus anterior.
Okay. And what will require for overhead rotation? Which bones or what is involved?
Scapular rotation is also involved along
Yes.
along with the glena rotation. The scapula has to rotate.
Okay, can you please tell me what are the factors which decreases the stability of the shoulder joint?
Factors decreasing the stability, the bony anatomy, the
Yes.
head of the humerus is
Yes.
larger compared to the size of the glenoid cavity.
Yes.
Then the
Okay.
ligaments.
Yes.
I'm
All right.
sorry.
Can you please tell me what type of joint is shoulder joint?
It's a synovial joint, ball and socket joint.
Okay. Can you please tell me what are the structures which are attached to the coracoid process?
The structures which are attached are the short head of the biceps, the
Yes.
coracobrachialis,
Yes.
and the insertion of pectoralis minor.
And ligaments? 3 ligaments.
The ligaments are the coracoacromial ligament,
Yes.
2 coracoclavicular ligaments, the kanalen and trapezoid ligaments, and
Crocohumeral ligament. Yes. Okay, can you please tell me what type of image are you looking at? Can you identify the image? What is it?
This is an MR MR arthrogram.
Yes, of the shoulder. Can you,
MRI image.
yes, can you
Of the
please
shoulder.
identify the blue circle structure? What is one, please?
One is the acromion. 4 is the lateral end of the clavicle.
Okay, and 5?
5 is the deltoid muscle.
What is the nerve supply of the deltoid muscle?
Axillary nerve supply is the deltoid muscle.
Okay, when there is injury to the axillary nerve, how the patient will present?
Patient will have motor deficit, like inability to act due to the weakness of the dullness in its distribution line. That's the area over the surface of the deltoid
Badge area.
muscle.
Yes.
Badge.
What is 6? 6.
6 is the glenoid
Cavity.
bone, glenoid cavity.
Okay. All right. Can you please tell me what nerves are in relation or in close proximity to the shoulder joint?
Nerves, axillary nerve.
Axillary nerve, which is
While,
branch of, or can you please tell me how brachial plexus are formed?
brachial plexus is formed by the cervical roots from C5 and C5 to T1. Then they form the C5 and C6 joint to form the upper trunk. C7
Yes.
continues as the middle trunk, and T8, T1 continues as the lower trunk. And all of them divides into upper and lower divisions. The upper divisions of the superior trunk and the middle trunk forms the lateral cord. Then the lower divisions of all the trunks forms the posterior cord, and the anterior division of the lower trunk continues as the medial trunk, a medial cord. Okay. And all of them branches into terminal branches.
Right. In examination, they might ask you to draw the brachial plexus. So this concept of brachial plexus should be very, very clear. And also, what part of brachial plexus is found where? So roots, trunks, divisions, and cords. So you have to tell, you should know, because axillary nerve is involved, so axillary artery is there. So second part, cords are around it, and all these, the branches. So they will simply give you a pen and a paper, and they might ask you to draw brachial plexus. So this concept should be very clear. And then if they can ask you about the injuries, what do you understand by the Erb's paralysis? So what will be the motor loss? What will be the sensory loss? How would you differentiate Erb's paralysis from Klumpig's paralysis? Yes, so you have to know this difference, right? Dermatome in case of brachial plexus. No BC amputation. Okay. So yeah, dermatome also they can ask you. It's given here in this of the arm. Yeah, back and front. All right, good. Little fine. Started the timer, and here is the question. Right. So if you have read and understood, considering it's surgical administration, kindly tell me, what are you looking at? What is this?
Yes, this is cubital fossa.
Okay.
Left
What are
left
the boundaries?
boundaries. Yes, as regard the laterally, superior laterally will be the brachioradialis muscle, and as regard medially with pronator teres, and the midline and the base of the triangle of cubital fossa will be imaginary line transverse between the two condyles.
Okay. Can you please tell me what are the contents of cubital fossa?
Yes, the content will be started from the medial to lateral, will be the medial nerve, brachial artery, bicipital tendon, and the most
Yes.
laterally is the radial nerve. Okay.
Yes. Can
And
you
the
please tell me what are the superficial veins which are present in
superficial
front of
vein,
the elbow? Yes.
superficial, the median cubital vein between the cephalic and the basilic.
Okay, good. Right. Can you tell me how elbow joint is formed?
Yes, as regard is bony content of the elbow
Yes.
between the lower part of the humerus and the upper, the head of the radius and the
Yes.
olecranion of the ulna.
Yes.
The olecranion will be articulate with the olecranion fossa, the posterior aspect of the lower part of the humerus, and the head of the radius will be articulate with the capitulum of
Yes.
the lower part of the humerus, and also the trochlear notch will be articulated with the trochlear of the lower part of the humerus, and the coronoid process will be movement on the coronoid fossa in the anterior surface of the lower end of the humerus.
Can you identify the structures from A to F? What is A, please?
This is the median nerve.
B.
C
B.
C is the B.
Yes.
B is pronator teres muscle.
C.
C is ulnar artery.
D.
D is cephalic vein.
Okay. F. E. Sorry.
E is brachial artery before division.
F. Yes. F.
F will be bicipital tendon of biceps muscle or bicipital tendon.
G.
G is brachioradialis muscle.
H.
H is radial artery.
Okay. Can you please tell me how what inserts on the radial tuberosity?
What insert where? Can
On
you
the
restate the question?
radial tuberosity? What muscle?
Flexor carpi radialis.
No,
muscle.
biceps muscle inserts.
Inserted by okay, the bicipital tuberosity of the radial
tuberosity.
of the radius. Yes, radial tuberosity of
Yes.
the radius. Yes.
Okay, can you please tell me if there is injury or if there is injury at the region of elbow and there is radial nerve injury, how would patient present?
Radial nerve injury at the elbow. The patient will be presented by wrist drop and finger drop and weak hand grip. Weak hand grip. Radial nerve injury.
How is it different from wrist drop? If the injury occurs at the elbow or radial nerve injury occurs at the wrist?
I'm sorry. If the radial nerve at the elbow will
Yes,
be
please.
different from the fracture humerus as the spiral groove. At the elbow will be finger drop, while more proximal will be wrist drop and finger drop.
Okay.
Yes.
Can you tell me which nerve is related with the medial epicondyle?
Ulnar nerve.
Okay, what happens when there is a damage to the ulnar nerve?
Claw hand in the form of flexion of the fourth and fifth digits, loss of sensation.
There is no, with medial epicondyle, if it's like a funny bone, it gives you sensation of tingling. Okay, can you
Sensation.
please, yes, can you please
Yes,
tell me what is the cutaneous deficient if there is injury of radial and ulnar nerve?
if the patient was have ulnar and radial nerve, both.
Injury. So what will be the cutaneous deficit?
Yes, as regard the radial nerve, loss of sensation over the first web space, dorsal surface, and
Yes.
regard the ulnar nerve will be loss of sensation along the palmar aspect of the ulnar third of the palmar aspect of the hand, and
Yes.
both the fourth and the fifth digits, including the palmar aspect and the dorsal aspect.
Okay, can you please tell me what are the movements which are present at the elbow joint?
Movement,
Yes, please.
flexion, extension, supination, and pronation.
Which muscles are responsible for these movements?
Yes, as regards the flexion, will be biceps, brachialis, coracobrachialis, and brachioradialis. And as regards the extension, triceps muscle, and the supinator also with the flexor, the same with flexors.
What
And
is
pronator teres. Yes.
What is olecranon?
Olecranium is the upper part of the ulnar bone.
Okay.
That has olecranial fossa and articulate with the olecranial fossa of the humerus, and bounded anterior with coronoid process, which articulate with coronoid fossa of the humerus.
Okay. If there is injury to the median nerve, so in
Yes.
the arm,
Yes.
in the forearm, what
Yes.
will be the cutaneous deficit?
Loss of the sensation along the radial 2/3 of the palmar aspect of the hand, and also the palmar aspect of the radial 3.5 fingers,
Yes.
and the dorsal digits of the thumb, index, and middle finger, just dorsal digits.
Okay. Can you please tell me what are the muscles which are responsible for the flexion of the elbow joint?
Yes, I said biceps, brachialis, coracobrachialis, and brachioradialis.
Okay, good. Right. Which part of the humerus? Maybe you've already told. It's just a repetition.
Which?
Okay.
Which part of the humerus?
The humerus is involved in the participation or the formation of elbow joint.
I didn't hear the question, the last part of the question. Which part of the humerus? What
is involved in the participation or the formulation of the elbow joint? Yeah, I think you told
yes.
me already.
Yes, the lower part, which is trochlea and the capitulum.
Yes.
Trochlea and yes.
Right, bell has gone, and I think I have covered whole upper limb almost. I think there was one more after this. Or yes, can you identify these tendons in this picture A? What is one?
This is palmaris longus muscle.
Two?
Flexor carpi annaris.
Three? Okay.
Yeah. Yes.
In B, what is A?
Muscle.
Yes.
Brachioradialis.
B. Then C is a vein. D and E as well. All right.
E is vein.
Yes. D as well. Yes. One can see.
Yes, median cubital.
Yes. Good, thank you. In picture A, one is flexor carpi radialis. Okay. And two is flexor digitorum superficialis. And three is flexor carpi ulnaris tendon. Three is flexor carpi ulnaris.
Mohammed, I think I mentioned two as palmaris longus. I'm sorry.
Yes,
Ma'am said it
palmaris
correctly.
longus is absent here. So two is flexor digitorum superficialis. Three is flexor carpi ulnaris. One is flexor carpi radialis tendon. Right, and then in here, they wanted to know A is lateral cutaneous nerve of the forearm, B is medial cutaneous nerve of the forearm, and C is medial cutaneous nerve of the forearm, and then E is median cubital vein, and the D is a tendon basically, right? So it's a brachioradialis tendon. Yes, clear? Right,
Again,
then, yes, again,
I looked
from
at the
picture A,
network.
from picture A, I tell again, one is flexor
Yes.
carpi radialis tendon. Where is one? Flexor carpi radialis tendon. Two is flexor digitorum superficialis, right? And three is flexor carpi ulnaris tendon. Then in picture B, one is A is lateral cutaneous nerve of the forearm. You can see it's lateral because here is the thumb. So this is lateral. B is medial cutaneous nerve of the forearm. So nerve is not visible, but somehow that's how it is labeled. And that's what I wanted to kind of understand, that if you can identify the structures in the arm and forearm and hand. C is medial cutaneous nerve of the arm. And then E is median cubital vein. And then D is actually the bulge brachioradialis muscle, which they asked in the book. So yes. Right, thank you. Now I guess it's clear. Started the timer, and here is your question. Right. If you have read and understood, considering it critical care scenario, how would you manage this patient now?
Yes, as regards this patient is RTA patient, so will be managed according to ETLS protocol.
Good.
Through ABCD approach. According to the airway, the patient attending now with Glasgow Coma scale is 8. So it is an indication to intubate the patient, but I just must look for any foreign body and any laryngeal injury, airway securing. But
Good.
at the same time, I must cervical spine immobilization and the alignment, form of hardboard, tape, and sandbag. This is and search for any maxillofacial injury and so on in foreign body. And then I will pass to the breathing to search for any apparent injury in form of flail chest, open chest injury, unequal chest movement, percuss note to detect any presence of pneumothorax or hemothorax.
Yes.
Listen to detect any
Can you please tell me?
or open. Yes.
Can you please tell me if
Yes.
what are the indications or benefits for? Can you please tell me what are the benefits? My computer wants to close.
Indication
Benefits of indication. Yeah, indications of intubation, please. I'm sorry.
for intubation.
Intubation, yes. What are the benefits of intubation?
Proper securing airway. The patient is the coma scale is less 8, so unsecure airway is unsecure. Proper oxygenation for the patient.
Yes.
Yes, and proper oxygenation, patent airway. And the
So
other
these are the benefits. Proper.
Yes.
Okay.
Indication. You need another indication.
No, I wanted to hear the benefits of intubation because you said patient has Glasgow coma scale 8 and you want
Yes.
to intubate it. So what are the
Yes.
benefits of intubating the patient? Okay. What investigations would you do to confirm your diagnosis at that time?
Is according to the patient, this patient is indicated for CT due
Yes.
to the as the Glasgow coma score is
8.
15, but
Okay.
he vomited twice.
Yes.
And dropped after that within 15 minutes to 8. This as regarded the focused investigation for this patient. But
okay. Considering the
otherwise,
NICE guidelines, what is the criteria to ask for CT scan in
yes,
head
the
injury?
first one drop of Glasgow coma scale
Yes.
within 2 hours below
Yes.
15.
Yes.
Yes, and the second one is suspicious of the depressed or open fracture.
Yes.
The third one is suspicious of fracture base of the skull in
Yes.
form of otorhinorrhea or battle sign or rock on eyes.
Yes.
Another one, old age for more than 65,
Yes.
or the patient in the anticoagulation.
Or
And
patient
another,
had more than 2 episodes of vomiting. Okay, can you please tell me why patient has dropped in Glasgow coma scale? It was 15 and it has dropped to 8. What has happened?
yes, maybe the patient in what we call lucid interval, in which
Okay.
the patient
What is lucid interval?
Yes, this is a temporary time of improvement of the patient conscious level. After that, there is a disturbance of the patient conscious level would decrease, during which there is accumulation of blood in the extradural space, causing extradural hematoma and the increase intracranial pressure and decrease the level of consciousness.
Okay, can you please tell me what is normal intracranial pressure?
As regard the normal cranial pressure between 7 to 15 millimeter mercury in supine position.
Are there any ways you can measure intracranial pressure?
In ways to measure, there is
Yes.
non-invasive and invasive.
Yes.
Non-invasive in form of transcranial Doppler tympanic membrane displacement, and the invasive one in form of intraventricular probe, intraparenchymal probe, extradural and subarachnoid and lumbar puncture probe.
Okay, can you tell me the pathophysiology behind how intracranial pressure increases?
Yes, as regard brain is like a box with 3
Yes.
components. Brain is 80%, blood and CSF, each one is 10%.
Yes.
Each one increase in the volume, the other one will compensate by decrease in the volume as auto-regulation till reach 25 millimeter mercury, in which any increase in the volume of any of 3 components leading to increase intracranial pressure, more and more cerebral increase intracranial pressure, cerebral edema, and may lead to coning or conization.
Okay, good.
And the
Can
loss
you
of
please tell
auto-regulation.
me if you
Yes.
suspect that patient has increased intracerebral pressure, would you
Yes.
go for lumbar puncture?
No, to avoid a brain herniation or conization
Okay, good.
due to sudden decrease pressure of the intracranial pressure.
Yes. So
Yes.
can you please tell me this Glasgow coma scale? It stands for what? What are the components of Glasgow coma scale that you consider?
three component of motor response, verbal response, eye response.
Yes.
The maximum score is 15. The least score is 3.
Yes.
Yes.
Okay. Can you please tell me, if you'll do the CT scan, how do you expect CT scan to be? Can you read this image?
Yes, this is axial CT scan brain showing biconvex lenticular shape, hyperdense area with midline shift and compression of the ventricles.
If a patient has raised intracranial pressure, why
Yes.
patient will present with dilated pupil?
Yes, due to increased intracranial pressure, dilated pupil due to a palsy of oculomotor nerve, which supply oculomotor nerve, which supply the all muscles, including the sympathetic sphincter pupillae muscle, on pressure or praxia of this nerve, leading to mydriasis, dilated pupil.
Okay. Can you please tell me what management can you offer to the patient who has raised intracranial pressure?
Yes, as regard management according to ABCD protocol, but precisely according to intracranial pressure. The first one, proper after intubation, proper positioning of the patient, 30 degree, then increase venous drainage through avoid tight tape of the tube with fixing with trousers. Then after that, I will I will give the patient measures to decrease intracranial pressure in form of mannitol and furosemide in dose 0.5 to 2 and 0.5 to 2, but milligram for furosemide and the gram for mannitol to decrease. Yes, after that, I will decrease the temperature of the patient and decrease cerebral metabolic rate, form of sibutone and anticonvulsant in case of seizures. Another one to decrease the cerebral blood flow volume by permissive hyperventilation to decrease the CO2, and the last resort will be craniectomy. The other one to decrease CSF by lumbar by external drainage in form of external ventricular drainage.
Very good. Okay.
Yeah.
Right. Yes, I have asked you more or less. Okay. Right. Thank you.